Okay, welcome everybody to the Neurotrauma Evidence Synthesis Training. This is a lecture series that's part of the NEST project. And so for those of you that are part of that project, I think you already know what it is, but the Neurotrauma Evidence Synthesis Training is a TBI or traumatic brain injury focused mentored evidence synthesis training where we're basically training doctors, medical students, and any other researchers how to conduct evidence synthesis, including systematic reviews, meta-analysis, umbrella reviews, and scoping reviews. And Dr. Goldenberg is here today. He's the head of the methods section of this, and I'm Richard D. Batson, or Davis, as you guys know me, and I'm the director of the content education portion. And we're very grateful to have Dr. Virtaj Singh today, who is a physical medicine and rehabilitation physician. He's also, I believe, board certified in pain medicine as well, and he will do his own introduction. I've known Dr. Singh for 5 or 6 years. He's here in Seattle, Washington. He's also the medical director of our professional rugby team, and he's a really interesting guy because he gets to see concussions from the time that they happen on the field through the chronic rehabilitation phase. And for those of you that are in sports medicine and so forth, he's an unbelievable resource. And I referred a lot of my patients to him, and he's been extremely helpful over the years in helping to rehabilitate many of our TBI patients. In terms of disclaimers, as you all know, the lecture today will be for educational purposes only. And it's not as a basis for assessment, diagnosis, or treatment of any health problem or medical condition or disease. And if you need help with that, please consult a licensed physician or other qualified healthcare provider. And it's all the images and other things in here use in accordance with fair use. And of course, please don't replicate any of the content here without Dr. Singh's permission. So without further ado, Dr. Singh, take it away.
Yeah, hi. I am very happy to be here. Thank you for having me. We are going to be talking about post-traumatic headaches, and in particular, from my perspective as a physiatrist, as a pain specialist, I'm going to talk about how I use various pain interventions to try and evaluate and treat post-traumatic headaches. And I think this really does overlap well with brain injury because commonly what I have found is people who have had brain injuries, oftentimes there's a whiplash type injury to the neck. So there's a big overlap with whiplash and brain injury and what we're going to be talking about today. A little bit of background about me. I was actually born and raised in Alabama. People find that hard to believe when they see me. One of the reasons I bring that up is we think about things very simply in Alabama. And so I like to apply how that sort of simplified thinking to how I approach medicine. I did my residency in physical medicine and rehabilitation at the University of Washington. So I'm a physiatrist. I treat people with head injuries all the time. But I also did a fellowship in pain medicine in the Department of Anesthesia. And I'm going to talk about how I've learned multiple approaches to how to treat patients and how that applies here. So next slide, please. So in my training, I have learned 2 different models for how you treat people with injury. The physical medicine model is the one where you try to find the dysfunctional segment and rehabilitate it, whether that be through physical therapy, occupational therapy, chiropractic, massage. You try to find what segment's been injured and what do you need to do to restore normal function to that segment. But in the anesthesia pain model, what we have learned is you find the pain generator and you block the pain generator. What anatomical structure is causing the pain, and how do you numb it up and treat it from that perspective? And what I have found is that the best approach integrates both models. Use various interventions and injections to try and pinpoint where somebody's symptoms may be coming from, but then also rehabilitate those segments. So like, for instance, when I was in my fellowship, oftentimes we would just numb up somebody's pain, but we wouldn't do anything to rehabilitate the segment. Or if I was just applying a physical medicine model, we would just be rehabilitating the segment, but nobody was doing anything to try and stop the pain. So it's usually the combination of both models that I found to be effective. Next slide, please. So before we start, I want to have a case discussion. We have a 27-year-old female involved in a rear-end motor vehicle collision. This is a very typical type of patient that I see in my clinic. Develops a variety of symptoms, including neck pain and headaches, and oftentimes they could also have a concussion. Headaches seem to be coming from the base of the neck, going into the forehead, a common referral pattern when the headaches are coming from the neck. You get x-rays of the neck. Oftentimes it doesn't show fractures, but it might show straightening. So the neck typically has a curve to it. One of the first things you'll notice when people have had trauma is that curve straightens out. They oftentimes start off with an evaluation in the emergency room. They're oftentimes told, okay, there's nothing, no brain bleed, there's no fractures, you're fine, just give it a few days. They're given anti-inflammatories and muscle relaxants, and then they're sent home. They have nothing, they don't know where to go from here. Next slide. So oftentimes these people have whiplash associated disorders. That is a broad category of symptoms for people who've had a whiplash motion to their neck. Now, obviously the main symptom is going to be neck pain. That's the one people typically complain of. But there are other associated symptoms, many of which overlap with concussion, many of which could be coming from the neck. So when you're dealing with people who've had some kind of traumatic injury, whiplash to the neck, and they're having a variety of symptoms, you have to sort of think about which of these is coming more from the brain versus the neck versus some combination of both. But those other symptoms can include headaches, dizziness, various areas of numbness, ringing in the ears, visual changes, cognitive changes, back pain, TMJ pain, etc. So you can see that if you looked up post-concussion syndrome and you looked up whiplash-associated disorder, there is going to be a lot of overlap. Next slide, please. So when you're talking about the headache in particular, there are different types of post-traumatic headaches to think about. Number one, you have your post-concussive headaches. Typically, when I think about headaches as they relate to concussion, I usually think of the headache as like the body's alarm system. It's kind of the final denominator when you've done too much. So when you've had a brain injury, as you know, we all have a certain level of battery that we have. When you've had a brain injury, your battery gets reduced. And I think of headaches as being what happens when you fully discharge that battery in the setting of a concussion. So it could be that they'll say, okay, I get headaches at the end of a long day, or when I've been staring at a screen for too long. Those are your typical post-concussive headaches. Usually they can sort of feel like a band around the head. Sometimes they can look like migraines. Also, you can get post-traumatic migraines, especially if you have a previous history of migraines. When I think about my classic migraine type headaches, I think about that headache where people hate lights and sounds. They really, really need to shut themselves down, put themselves in a dark environment. And you can imagine that happens with concussions as well. Too much stimulus can be overwhelming to the system. That's a lot of overlap with concussion headaches and migraine headaches. With migraine headaches, you're usually thinking about people who have auras beforehand. Usually they feel this pounding behind one eye. You can get tension type headaches following a motor vehicle collision. As you can imagine, with the whiplash type injury, those neck muscles can get super tight, and that can end up feeling like there's a vice grip around your head and neck. Typically, your tension type headaches are the ones where they feel like there's a band around their head. Maybe their muscles feel tight, but that's your tension type headaches. One of the type of headaches to pay attention to when somebody's been in a collision are your medication overuse or your rebound headaches. One of the mistakes people make when they start getting headaches is they start taking ibuprofen around the clock. The problem is if you become too used to that, or if you're taking caffeine or Tylenol, whatever it is, and you're taking it more than 3 times per week, you can get into this cycle of rebound headaches. In fact, when sometimes people are having chronic daily headaches, even after trauma, one of the first things you have to do is get them off short-acting medications, just in case that's playing a role. Then there's this entire category of headaches called the trigeminal autonomic cephalgias. Those are the headaches that oftentimes are associated with like runny nose, tearing up of the eyes, droopy eyelids, those sorts of things. So it's a completely different category of headaches, but I want you to be aware of it because you can get it after a collision. Next slide, please. But what we are primarily focused on in the setting of post-traumatic headaches are those headaches that we call cervicogenic headaches. In other words, these are the headaches that seem to be coming from the neck. And I've put the International Headache Society criteria on here. There's a few things I want to point out. Number one is obviously the pain is coming from the neck. And typically what people will describe as pain that's coming from the back of their head and upper neck and goes into the forehead region, but it can actually go into the face as well. Now, they ask for clinical laboratory or imaging evidence of a disorder or lesion within the cervical spine. What I can tell you is these people rarely have anything that shows up on imaging. So that can be a big misleader for people, which is they'll get imaging of the neck, maybe they'll even get an MRI, and it won't show anything obvious. But that's typical, even in whiplash injuries, that there's not something, maybe the straightening of the neck, but there's usually otherwise not any evidence of an anatomical injury. We can talk about more. Criteria C, evidence can be attributed to the neck disorder based on the temporal relationship to a cervical disorder. So in other words, it's a headache that developed after an injury to the neck, i.e. like a whiplash injury. And part B is the most important. Headache is abolished by a diagnostic block of a cervical structure. That's oftentimes where I come in. We try to identify what is the structure within the neck that we think is causing the headache, and then we try to anesthetize that structure, numb it up, and see if their headache goes away. And then criteria D is there's no better explanation for the headache or alternative diagnosis. In other words, you've ruled out migraines, you've ruled out other possible source of the symptoms, and we think it's coming from the neck. Okay, next slide, please. So what are the anatomical structures within the neck that can cause cervicogenic headaches? Well, you have your disc injuries, and most oftentimes people think of the disc as being the main thing when they think about something that got injured in the neck. So whether it be a herniated disc, etc. I can tell you, I don't oftentimes see that as the primary injury, and those are the types of things that can show up on imaging if you get an MRI of the neck. So it's listed, but I don't think of it as a typical cause. The most likely cause is an injury to the upper cervical facet joints. And I don't know how many of you know what the facet joints is. Davis, do you mind going back to that next slide real quick? The picture of the neck. I should have put a good neck picture, but we can go right there. So, and can you see my arrow on the screen? Okay, so I have an arrow. I don't know if you guys can see it, but the facet joints are these joints in the back of the neck, and they're numbered down starting with C23, C34, C45, C56. These joints, so those joints on the back of the neck, that where the arrow is pointing is your C23 facet joint. That is the most common cause of post-traumatic headaches. It's the most commonly injured joint when somebody has a whiplash injury to their neck. So the upper cervical facet joints are the most common cause of post-traumatic headaches. You can also have myofascial tightness. We talked about that before. The neck muscles get so tight, they end up irritating the nerves, and those nerves are typically the occipital nerves. You can also get an injury to something called the trigeminocervical nucleus. And I'm going to bring that up, and I'm going to show you a slide in a minute about that, but I want you to know about this because what confuses some people is sometimes people develop facial pain after a collision. And facial pain is almost an entity in and of itself, but it can occur concomitantly with cervicogenic headaches because of this trigeminocervical nucleus. So what that's talking about is the trigeminal nerve and the occipital nerve actually communicate with each other, and you can have these overlapping symptoms. Next slide, please. That is your occipital nerve. That is the one that is often perfect. That is the one that is oftentimes causing cervicogenic headaches. They come from the base of the neck. But then if you go to the trigeminal nerve, that's the trigeminal complex, that's what leads to your trigeminal symptoms. Those are the ones that can either go into your jaw, your face, or your forehead. What you could see is those nerves actually communicate through this trigeminocervical complex. That's all that yellow stuff that's on the screen. The reason I bring that up is just so you know that cervicogenic headaches, post-traumatic headaches can also cause facial pain, and they can play off of each other. Okay, next slide. So what are our different approaches? There are different schools of thought. I call some people the myofascists. These are the people who really believe in the myofascial approach to these types of symptoms. That's where you could start with like your massage and your soft tissue work. In my world, there's other treatments called IMS, which is intramuscular stimulation. Some people call it dry needling. And you have your trigger point injections. So some people might approach these headaches from an interventional standpoint by going after the muscles and the soft tissues. Then you have your needle jockeys, that's also like me, that think that the pain is coming from discrete nerves. That's where we have treatments like occipital nerve blocks, which I'm going to talk about, facet joint injections, and then ultimately there's a procedure called a radiofrequency ablation, which might be the best, most definitive treatment for some people for getting rid of these cervicogenic headaches. Then you have your wackos, also a category I belong to. We believe that it's ultimately ligamentous disruption. Ligaments are the glue holding those bones in your neck together, which leads to instability, which leads to pain. And when that's the case, we have various treatments like prolotherapy and PRP. I'm telling you, this world right now is where I'm having a lot of my best success is doing those type of treatments, even though that labels me as a wacko. Next slide, please. So if you start with the most conservative approach, that would be the myofascist approach. Once again, that's under the idea that the pain is coming from chronic muscle tension. Now, I can tell you a lot of people don't accept myofascial pain as a distinct problem. In other words, they think, well, the muscles can be tight, but usually that's because it's driven by something else. And they see treating it as some akin to like treating a sore throat, but not treating the bacterial infection that's causing it. So in other words, it's like you're treating the symptom and not the cause. I understand why people think that, but for some people, if you can treat the soft tissue muscle fiber shortening, you can effectively treat the pain without having to do anything more aggressive. In my world, I have two approaches. One is intramuscular stimulation, also known as dry needling. The reason it's called dry needling is because you're not injecting anything. The needle is just used as like an acupuncture needle going deep into the muscle. Then you have your trigger point injections. That's where you're actually injecting something into the muscle, whether it be just a numbing medicine like lidocaine. Some people put steroid in there. Some people put Botox injections. Oftentimes, I'll put Trameal, which is a naturopathic anti-inflammatory, in my trigger point injections. Next slide, please. So what is intramuscular stimulation? It's actually a treatment developed by a doctor in Canada, Chan Gunn. It's based on the concept of muscle shortening. So in other words, if you think about the whiplash type injury as a primary strain type injury, STRAIN, where you strain the muscles of the neck, what that would cause is those muscle fibers to tighten up and shorten up. So, you know, people feel like their neck is tight after a collision. So the idea is, well, if I can loosen those tight muscles, get everything back to normal working order, they'll feel better. So typically what dry needling does is you take an acupuncture needle and you go deep into the muscle and you're trying to get the muscle fiber to release. There's these built-in muscle reflexes that you're trying to get to release. Typically, I would target the upper trapezius and the suboccipital muscles, including the splenius capitis and the splenius cervicis muscles. So the idea is if you can get those muscles to release, people will start to feel better. Next slide, please. Then you have your trigger point injections. That's where you're actually injecting something into those muscles. This was a technique developed by Simon and Travell. There's big books based on it. It's based on this concept that people have distinct trigger points. Now, if you've ever heard somebody saying, oh man, my neck is so tight, I have these knots in my neck, that's those trigger points. Trigger points are these distinct bands of muscles that when you push on them seems to cause this referred pain. And a bunch of these trigger points, excuse me, can trigger these sort of headachy type symptoms. So that's what you look for with trigger point injections. You look for these distinct taut bands in the muscles, and then you inject something into them, whether it be lidocaine or lidocaine plus something. And you're typically going after muscles like the trapezius, levator scapula, the suboccipitals. You can go after the masseters, the temporalis frontalis, sternocleidomastoid. There's a bunch of different muscles you can target with trigger point injections. Next slide, please. Now, my approach that we've talked about is where you're actually going after the different joints in the neck from an interventional standpoint. And this is where my whole pain fellowship came in, because these are highly technical procedures. So there are several areas that are thought to be the cause of the pain when you go deeper. One is the atlantoaxial joint. That's the joint where the top of the neck meets the top of the bottom of the head. And that's thought to account for up to 16% of people with occipital headaches. But the most common, accounting for 53% of people with post-traumatic headaches, is that C2-3 facet joint that we talked about earlier. And that is innervated by something called the third occipital nerve. So if you ever see somebody doing a block of that joint, you might see it called a third occipital nerve block. And like I said, this is a very common cause of cervicogenic headaches after a whiplash type injury. Off of that third occipital nerve, you have these greater and lesser occipital nerves. These are the nerves that run up the base of your skull. And those can be targets for interventions as well. So these are various nerves that I can target with my interventional treatments. Next slide, please. So this is a good picture of it. Once again, you're looking at the nerves as they come off that C2-3 facet joint and go into the base of the skull, and those travel into the forehead. So you can see the greater and lesser occipital nerves. Next slide, please. So what do? The first thing I oftentimes do is I try to block those occipital nerves. That's actually one of my favorite procedures to do, because oftentimes people who've been dealing with headaches since a collision, this might actually break up that headache pattern, and they might walk in with a headache that hasn't left since a collision, and I do this block and all of a sudden their headache goes away. And this is a very simple block to do. I use my ultrasound machine and I find the occipital nerve, and then I inject some numbing medicine steroid. So sometimes I'll start with IMS and trigger point injections, but other times I'll jump to this as a first line procedure. It's amazing how people will buy into your treatment program if you can make their headaches go away day one. And another thing you'll notice is oftentimes your people who've had brain injuries that don't seem to get better, if you can take away that headache pain, you will see all the different symptoms that get better. I've had people tell me their ringing their ears gets better from occipital nerve blocks. I've had people tell me their vision gets better, that they start thinking more clearly. So sometimes if you can take away those headaches, a lot of other symptoms can start to get better. Next slide, please. If the occipital nerve block doesn't get you where you want to go to, then you can start going after those facet joints, including the C2-3 facet joint. One of the things I might start off with is to do a steroid injection to the joint. Or you can do a diagnostic third occipital nerve block. That is where you're just numbing up that joint and seeing if their headache goes away. That, if you remember when we talked about the criteria for headaches, and they talked about reliably getting the headache to go away by numbing up these structures, that is a perfect example of a procedure you can do. You do it under X-ray guidance, you numb up that nerve, and you see if their headache goes away. That's how you can prove their headaches are coming from their neck. If you're able to successfully prove that, then you can ultimately consider a procedure called a radiofrequency ablation or radiofrequency neurotomy. That's where you're basically cauterizing the nerve to the joint to try and get the headaches to go away. And for some people, that is the most definitive procedure you can do to get these headaches to go away. Next slide, please. So what is the process to getting towards a radiofrequency ablation? So the current process is you have to do 2 separate numbing blocks on 2 separate occasions using 2 different numbing medicines. On one occasion, excuse me, you're using a short-acting anesthetic such as lidocaine, and on another occasion, you're using a longer-acting anesthetic such as Marcaine. If they get what we call a positive concordant response, which means with the lidocaine, their headache goes away, but for a short period of time, and then with the Marcaine, their headache goes away, but for a longer period of time, if that happens, you can go on to the radiofrequency ablation procedure. Next slide, please. Now, you might say to me, why not just block the nerve one time and then burn the nerve? The problem is if you just do one set of blocks, it has up to a 33% false positive rate. But if you use the comparative blocks that we talked about, false positive rate decreases to 12%. So in other words, if you do the blocks, 2 different numbing agents, 2 different occasions, 2 different lengths of response, you can be almost 90% sure their headache will go away. So people like that level of confidence. Unfortunately, if you use really strict criteria, your false negative rate goes up to 46%. So unfortunately, if you're too strict with your criteria, you could be ruling out too many people that could benefit from the procedure. And so I like to think about what's my pretest probability as I'm interpreting these results. Next slide, please. So what exactly is a radiofrequency ablation? It kind of scares people to think about the idea that you're burning the nerve. You're basically using temperatures up to 80 degrees to coagulate that third occipital nerve. So under X-ray guidance, you take a heated probe. It's not surgery because you're not cutting the body, but it's a pretty invasive procedure. And you're just coagulating that nerve that's causing the headaches. If you use the careful selection criteria we talked about, up to 70% of people can get complete relief of their headache for about a year. Now imagine that somebody's having these daily intractable headaches after a whiplash injury, whether it be for weeks, months, or years, and you have a reliable procedure that can get it to go away with 70+% confidence for up to a year. That's a pretty profound procedure. And if the pain returns, excuse me, you can simply repeat the procedure. Now, the one big side effect is they can develop what's called a post-procedure neuritis. So when you burn that nerve, it can kind of make it feel like a sunburn back in the back of their head. And for a few weeks, that can be a little painful. Also, to remember, the same nerve that goes to the joint, the same nerve that you're burning, actually goes to the muscles themselves, which means that you are, to some extent, weakening the neck a little bit. So you have to take the pros with the cons on a procedure like this. Next slide, please. So what is the wackos approach? This is my favorite approach. This is where we think about something called prolotherapy. So the idea is that the underlying injury is to the ligaments, the glue that's holding the neck together. So in other words, when your neck has a whiplash motion, that glue gets disrupted, those ligaments get weakened, and your neck is now unstable. The analogy I use is imagine there's a fire in a room and the fire alarm's going off. And think of the headache as the fire alarm. The approaches I've talked to you about to this point, well, to some extent, we're trying, like for instance, steroid injections, you're trying to put out the fire. But oftentimes that fire just keeps coming back. So then with the radiofrequency ablation, it's like you're trying to cut the cord to the fire alarm. So those are two approaches, but what I think of prolotherapy is trying to do is it's trying to find the gas leak and turn the gas leak off. So in other words, what is driving the fire that is setting off the fire alarm? So rather than simply cut the cord to the fire alarm so you no longer have to hear it, why don't we address the underlying structure that is injured and is causing the fire? So what is prolotherapy? Prolotherapy is a procedure where you are purposely injecting an irritant to try to create inflammation to try and heal up those ligaments. So one of the big things to remember is our body has a really good capacity to heal itself. You know, like if you break your arm, put the bones back in alignment, the bones heal. The problem is certain structures do not heal well, in part because they have a poor blood supply. So these relatively avascular structure, like these ligaments, they don't tend to heal well on their own. So what prolotherapy is, excuse me, you are purposely injecting an irritant into these injured ligaments to try and create an inflammatory response, to try and get blood flow to the area, to try and heal up the ligaments. The hope is that if you can heal the underlying tissue damage, you can restore normal function and basically bring them back to normal. Next slide, please. So for my approach, it depends on what structures are loose, but you'll see there's a variety of different targets you can inject with prolotherapy. The presumption is this is where all the ligaments have been damaged and injured. Next slide, please. So the idea is you restore those normal ligaments, and hopefully their neck pain and their headache ultimately go away because you've actually taken a step to try and heal them up. Next step, please. So in our hypothetical patient, I would probably start with IMS and trigger point injections. If that's not working, I would move on to occipital nerve blocks. If that's not working, I'd probably do a C2-3 facet joint injection. If that wasn't still working, we might do the third occipital nerve block and the radiofrequency ablation. If that's not working, we might move on to prolotherapy and PRP. All the while, of course, while we're doing these intervention treatments, we're having them do their physical therapy, their massage, their chiropractic. And I always tell people, remember, time heals, the physician entertains. So we're trying to give people the best circumstances for their body to heal itself, etc. So next slide. And always don't forget, there can be other possibilities. Don't forget to look for other things. It doesn't necessarily have to be a neck-related headaches. All right, thank you very much. I think that was my last slide.
Fantastic. Thank you so much, Dr. Singh. I think there's a slide of your financial disclosures at the end that I really like, but I assume those are your cats.
Those are my cats.
Yeah, fantastic. Well, thank you so much, Dr. Singh. I'd like to open it up for question and answers now. So if anybody wants to ask questions, go ahead and unmute your microphones and jump in, and let's talk with Dr. Singh about the lecture and any questions you might have.
I have 2 questions and a comment.
And
can y'all hear me?
Is this Dr. Giannoli?
This is.
Okay. Good morning, Dr. Giannoli. Dr. Giannoli is going to be lecturing in 2 weeks. He's a basic skull surgeon and neurotologist that's north of New Orleans. So Dr. Giannoli, welcome, and please go ahead with your question.
Thank you. Excellent lecture, Dr. Singh. I really enjoyed it. I have 2 questions and a comment. The first is, I am not a headache doctor. I don't even pretend to be one. But the first question I have is, I remember reading somewhere that post-traumatic headaches cannot be migraines by definition. Is that the case?
Yeah, that's a great semantics question. Not that you're great question. Let's start with that. But it's a semantics point. The international criteria of headache people have their different ways of classifying it. And it's like, if you've ruled this out, ruled that out, it can be this or this. So that is an exclusionary way of thinking about it, which is if it's trauma, then by trauma, it's not considered migraines. As you know, migraines can be is more of a vascular event. What I would say is if you have a pre-existing history of migraines, motor vehicle collision trauma can make those migraines worse. But I tend to think that it's a mistake when people develop headaches after a collision and they get diagnosed with migraines. To me, the biggest key is, do the migraine medicines take care of the headaches? If they do, then I feel like they are migraines. You have your symptoms, but so if there's a whole new class of really effective medication for migraines, these whole CGRP meds. And if somebody tries one of those and their headaches go away, great. But when you're taking your triptans and it's not aborting your headaches, and you're trying these meds and it's not helping, and the conventional way you treat a migraine is not working, I think you need to think about cervicogenic headaches. And the mistake a lot of neurologists I've seen make is they get really boxed into trying to treat it as if it's a migraine. So I agree with you in that sense that they may be very distinct, but I have seen people with pre-existing migraines get worse after a collision, and I have seen them respond to migraine medications. But also cervicogenic headaches can cause migraines in a sense. Like you could see those transform, and you can see people with migraines have cervicogenic components. So to me, the way I would distinguish them is if I numb up the nerves in the back of your neck, do your headaches go away? To me, that's a cervicogenic headache.
Gotcha.
If it doesn't, but they're responding more to the CGRP medicines, maybe they're migraines, but I've seen people with components of both, and I've seen them play off of each other.
All right, second question. You mentioned the NSAID rebound headaches. I've always wondered how much is too much. I mean, is there a defining line when they have gone too far with the ibuprofen or what have you?
Great question. So a couple things. I don't want to get sued by the ibuprofen lobby. I am not the biggest fan of anti-inflammatories. I think they inhibit your body's ability to naturally heal, natural collagen synthesis, etc. The answer is typically if you're taking a medicine more than 3 days a week, that's too much and you're at risk for rebound headaches. But I'm not, okay, if I get a headache tomorrow and it's really bad, I will take ibuprofen. I'll take it one time with some caffeine. It tends to abort my headaches and then I'm fine. So in that sense, I see the role of ibuprofen. But when it's getting rid of it, but it's coming back, getting rid of it, it's coming back, I would rather do something more targeted like an occipital nerve block, something using steroid if you're trying to get inflammatory and try to put it down rather than these short-acting medicines.
Okay, and one comment, I just want to add to possible contributing factors or exacerbating factors for these cervicogenic headaches, the ear. Whenever someone injures their ear, and you don't need to have impact for that, you can get that with a whiplash as well. You'll get dizziness, you'll get tinnitus. And when you stimulate the ear, everybody thinks of the vestibular ocular reflex, but there's also a vestibular cervical reflex. And if you look at lower animals that have lost vestibular function on one side, their head will be cocked over like this because of all the muscle contraction in their neck. And we don't see that so much in folks, but they'll have some discomfort back there. Even patients that have never had trauma. And once you stabilize their inner ear, you see less stimulation of the cervical muscle. So I would suggest for the patients where it recurs or they don't resolve and they have tinnitus and dizziness, consider the ear because I find it's one of these things that goes way underdiagnosed and kind of falls under the radar because nobody really looks at it.
Yeah, I'll take it. 1,000,000% agree with you. When I think of dizziness, I think of some systems issue between the eyes, the ears, and the upper cervical spine. I think those three are playing a role. I tend to think of it as if 1 to 2 of those go out of whack, that's when people get dizziness, etc. Then the question for me is, where do we intervene to break this cycle? For some people, you might get away with just the neck. For some people, it might be vision therapy. For some people, it might be ear issues. The problem in our geographical area is we don't have anybody like you. I can send them to vestibular therapy. We used to have Alan Langman, who was great. I don't know if you know Alan Langman,
Yeah.
but I think he's retired. And I guess short of sending them all to New Orleans or wherever you're at, I don't know of anybody. I would love to have that piece here because I don't want to think, I'm not so spine centric that I think everything gets fixed with the neck. And I think it's the triad has to be looked at. Somebody needs to be looking at oculomotor dysfunction. Somebody needs to be looking at the upper cervical spine, and somebody needs to be looking at the inner ear. And we got to get all three of those systems back into their normal working order, because otherwise we're trying to treat this with just one problem. So if you want to move to Seattle, you will be very welcome in this geographical area.
Well, appreciate that.
I think we've got Dr. Gianoli. Any other questions before we bring Laura Higgins in for her question? Okay, Laura, go ahead.
Well, every time someone gives an answer, it spawns 5 more questions, so I'll try and be brief. Hello, and thank you for your talk. Can I presume that using the hot wire to fuse the nerve, the reason why it comes back after a year is because the nerve regenerates?
That's correct. Thank you. Sorry, I didn't say that. And for some people, it regenerates faster. So I've had many people get an ablation and they're like, oh my God, my headaches went away, but they came back after 3 months. Now, typically, if you burn it a few times, at some point it might burn itself out. and usually it could be 3 to 5 times is that sweet spot. But I like the radiofrequency ablation procedure, but I think it's an imperfect procedure because you're not treating the injury, you're treating the symptom, and because the nerve can regenerate. So it's a thing that you might have to keep repeating. But you're completely correct. The reason the pain comes back is because the nerve does regenerate.
I'm just impressed with nerves regenerating because a lot of times that I've heard people say, "Oh yeah, your nerve's gone. That's it. It's never coming back." So I'm happy that nerves do regenerate within a year or faster. Sad that it doesn't work for this procedure, but yay. Second question. You mentioned that if you're going to take an NSAID, you do it with caffeine. I'm not aware of the fact that caffeine increases the effectiveness of
So
an NSAID.
two different things. So
Okay.
caffeine can be very helpful for migraines. Now you'll find that some people get rebound. Oh, have you ever heard of people getting rebound headaches because they drink too much caffeine if they're not getting their coffee, etc.?
Yes. Yes.
I stopped all caffeine because I found that for me personally, when I get migraines or when I get headaches, I can break the cycle with a combination of caffeine and anti-inflammatories. Not that they're working together, but that combination seems to be what takes. So I think the caffeine's working more on the vascular, and the NSAIDs are working more on the inflammation.
Okay. What is your opinion of chiropractic cervical adjustments? And I'm going to give a caveat to that. I've had really bad tinnitus for 2 years. I've been avoiding chiropractic cervical adjustment. I've had acupuncture, massage, ultrasound. I've had so many things. I finally let the chiropractor do a cervical adjustment and it went from a 7 down to a 3. So,
In the right hands, it can be very effective. Chiropractors probably understand this more than a lot of medical doctors. They are good at trying to get you back into alignment. At least some are, especially your upper cervical, your Nuka chiropractors, your Blair, etc. There's a subset of chiropractors that are really good at the upper neck, and oftentimes they will do very minor adjustments. The problem is, how do you keep it to stay in alignment? That's where something like prolotherapy can help. But if the ligaments are loose and unstable, chiropractors can be very effective at getting things into place. My criticism of chiropractic in the right hands, great. My criticism of chiropractic is twofold. Number one, they can sometimes overtreat. And it doesn't make sense because they get you back in alignment, you feel better, get out of alignment, and you're having to come back. So it's becoming this cycle of almost dependence on what they do. And number two, chiropractors tend to value mobility over stability. Remember, they're mobilizing segments. And at some point and in some phase, I can understand and agree with that. But ultimately, I value stability over mobility. So if something's stuck in the wrong alignment, I totally get wanting to pop it, move it out, get it back into normal alignment. Makes perfect sense to me. Chiropractors are great at that. But if I'm trying to get it to stabilize, you need to stop moving it around. So for instance, if I'm doing prolotherapy, I'll say maybe see the chiropractor for a few weeks before we start. But as we're going through prolotherapy, avoid manual adjustments unless you're clearly out of alignment. I don't want you just routinely getting popped and having them break up that tissue I'm trying to develop.
Yeah, I understand that. And then I can save this question for the next doctor that's presenting, but the description he just gave of the cocked head after a fall and the muscle stimulation. My mom fell on the steps and got whiplash and contusions on her shins. And ever since, she's been cocking her head to one side. So short of flying her down to you guys right now, anything I can immediately do to help her and relieve that? Just maybe massage, heat, that type of thing? I know you're not giving advice. I'm just saying I have witnessed what you just said.
I would think that
now
would be the easiest thing to try as a conservative approach that you could quarterback on your own. But obviously beyond that, you'd want to go see somebody.
Yeah. Okay, then. Thank you so much.
Welcome.
Okay, I think, do we have, thank you, Laura, and thank you, Dr. Singh. Do we have any more questions from the group?
Yes, I have three more questions. Laura asked one of mine. I'm wondering how long the nerve block typically lasts.
The nerve block where you numb it up.
Mm-hmm.
Okay, so it's a good question. There's two parts to the nerve block. So the lidocaine itself, if you're doing lidocaine, is going to last anywhere from 30 minutes to an hour and a half. It's a short-acting anesthetic, but it's the one that gives you that immediate response in the clinic. If you're using an anesthetic like Marcaine, that's a longer-acting one. That's going to last, excuse me, 3 to 4 hours. So typically with Marcaine, you wouldn't expect them necessarily for the headache to go away while you're in clinic, but later on that day, they're going to have long-lasting headache relief. But when I put steroid into these injections, the hope is that you either break the cycle if you do it early on and their headache just goes away and stays away, or typically steroid is thought to last up to 2 to 3 months. My experience has been when I do like an occipital nerve block with steroid, either it takes it away and it never comes back, or it lasts just a few weeks.
So is it like just masking the symptoms? So the anesthetics are just masking the symptoms. The steroid is like inflammation long term. Is there any component of like addressing the nerve sensitization, or is it really more just like inflammation and masking, like anesthesia?
Well, yeah, all of the it matters what the nature of the injury is. Let's say you see somebody early after a collision, and let's say the main problem is just inflammation. There is a chance that you put steroid in there, you put out that fire, and it never comes back. Let's say the ultimate problem is the joint is unstable. The ligaments have been disrupted, the joint's unstable. All these injections are going to be temporary. It's like you're trying to put out the fire, but there's the fire, there's the gas leak, and nobody's addressing the gas leak. Excuse me. So that's where our different approaches come in. In terms of the sensitized nerve, if you're talking about peripherally, lidocaine can help reduce that sensitization, as can steroid, as can any of the medicines.
Great. And then one more question. I was wondering, I think I heard that you said that you would do ablation before prolotherapy. Was that correct?
No, it's a good question. Excuse me. I have gotten to the point where I prefer prolotherapy over ablations. I was just giving you a hypothetical approach where one could do based on what people are more likely to do. I have sort of fallen out of love with ablations and fallen more in love with regenerative injections.
Okay, great. That's all my questions. Thanks for your presentation.
Thank you.
Okay, do we have any more questions from the group? Going once, going twice? Going 3 times? Good. Well, thank you, Dr. Singh. I think I want to reiterate a couple points that Dr. Singh mentioned, which is this partnership between the cervical, the inner ear, which is looked at through neurotology, and vision, which is looked at through neurooptometry. And I think at some point, Dr. Singh, Dr. Giannoli, it'd be fun to have a panel with you guys and then maybe bring in one of our neurooptometrists. And so we'll see if we can do that. Dr. Giannoli is going to be lecturing in 2 weeks. Again, he is a ear, nose, throat physician, subspecialization in neurootology, which focuses on the inner ear compartment. And central issues related to vestibular dysfunction as well. And of course, audiological issues that can arise after brain injury. But he's going to be lecturing on dizziness and disequilibrium or imbalance in the post-traumatic setting. You do not want to miss his lecture. He's one of our top physicians in the country and a wealth of knowledge. So that'll be, I believe, on October 18th. So I hope all of you can be there. And then I think after we finish our neurooptometry lecture, it'd be fun to invite Dr. Giannoli, Dr. Singh, and one of our neurooptometrists back to talk about this relationship between vision and really ocular motor function, which we've already had a lecture on, the vestibular function and the cervical component. So hopefully Dr. Singh will come back and see us again. And of course, you'll get to meet Dr. Giannoli in a couple of weeks. So Appreciate everybody attending. It will be this has been recorded, and we'll get it posted on Moodle for everyone as well. Thanks everybody for attending, and have a fantastic weekend.